LS Ascend family. Thank you so much for coming to our Tame the Flame event, brought to you by our amazing donors who raised over $6,000 so we can get Dr. Corey Babb to come and talk to us about flare management. Now, Dr. Corey Babb needs no introduction, but I will introduce him anyway. He is an amazing gynecologist in Tulsa, Oklahoma with the Haven Center. It's an amazing boutique kind of, I don't even know what the right words are. It's just an experience, which, we need. And he is just super smart and super funny. And I'm so excited to have him here with you. If you, what do you call them? Housekeeping thing is you do have access to the closed captions. You could talk to each other in the chat, and we will be taking questions after the presentation. So as your questions come up, drop them in the comments and we will grab them so that we can ask Dr. Babb afterwards. We appreciate all of our donors, like I was saying, because without you, we wouldn't be here. So if you haven't donated yet and you feel compelled to, please do. Until we currently have a $5,000 match. So every dollar that you donate today will be matched up to $5,000. And that is, again, thanks to our amazing community, the Simpson family. Thank you so much for that $5,000 match. So without further ado, let me introduce you once again to Dr. Babb. Welcome, Dr. Babb.
Hey, Kathy.
So excited to have you.
I'm
not going to take up any more time. It's your show. And
okay, well, thank you everyone for having me. I am so excited to be able to present this little kind of PowerPoint about managing LS flares. So, and obviously, like Kathy said, if you have any questions, put those out there and we'll get those get to them at the end of the recording there. And please forgive my voice. I'm getting over this cold that's been going around Oklahoma. And so I'm a little scratchy, but we'll kind of go from there. So without further ado here, Kathy, just to make sure, can you see my screen here?
Yep, I got your slides up.
Great. Okay, so we're going to get started here. So obviously we are going to be talking about lichen sclerosus flares, what we can do to help that. So kind of on this slide here, what this presentation is, we're going to talk about common lichen sclerosus symptoms and really how those symptoms kind of come together when you have a lichen sclerosus flare. We're going to also talk about therapies that you can do to help address those symptoms. And that's everything from different environmental changes, lifestyle changes, medications, all sorts of stuff like that. And then obviously just kind of this disclaimer, and I've used this in a presentation before, but this Shakespeare quote, all that glisters is not gold, from the Merchant of Venice. So everything that goes on the vulva isn't necessarily LS. So just kind of keep that in mind too. So what this presentation is not, obviously, is the end-all be-all of lichen sclerosus symptoms. You are a unique individual. Your symptoms are unique as well. Obviously, while this is educational, this is not a substitution for proper evaluation. Find an LS knowledgeable provider for that eval. And sometimes, unfortunately, you may have to see multiple providers to find someone that knows even what LS is, which is terrible, but we're getting better at that. And then also, these are not the end-all be-all of all, treatment options. There are things out there that are being newly researched. And so that's really exciting too. So anyway, so first of all, we want to talk about what really is a flare. So flare usually will manifest with a sudden increase in your lichen sclerosus symptoms. Now, this may be if you have an underlying itch, maybe that itch gets so bad that it's all you can think about, or if you're more of kind of a burning, scratchy type pain, gnat flares. It can also be just kind of a change in overall architecture where things start to really, you see more of a whitening of color or a decrease in architecture. And so that goes into that change of symptoms, that maybe it's something different too. Maybe you typically are more of an itchy person, but now it's, oh my gosh, I'm having a lot more burning. I'm not seeing that kind of itch. This is a sudden increase as well. And we can also see that any of those symptoms there, they may just get exacerbated, not only with lichen sclerosus too, but if you have other types of autoimmune conditions, you may notice that these go hand in hand. So if you have something like uh, autoimmune issue that affects your joints, like rheumatoid arthritis, lupus, things like that, maybe those symptoms flare too. So it can be a worsening of just current symptoms in general. And so we know that there are things that typically cause these flares, and here's just kind of a short list of them. The main stuff is going to be, is there a change in your immune status? And not necessarily, are you now immunocompromised or something like that, but is there something that's causing your immune system to do more activity than what it's used to? So illness is obviously a very common one. We will much like patients who get a cold sore when they get a cold, that's an activation of herpes virus infection. Similar type thing, you may get a really bad cold and that causes an LS flare. Or maybe you have surgery on something completely unrelated. You get your tonsils out, or you have a breast reduction, or whatever it may be, that could cause your LS to flare too. And then the other thing that we often see, especially in female patients or patients who are having menstruation that have LS, is that menstruation itself can bring about a change in LS and can cause symptoms to flare. This is really more due to a hormonal change in what's going on. Now, obviously, outside of immune status, you can look at things going on in just your underlying stress. Life stressors, they talk about kind of the main life stressors out there, whether that's going to be a change in relationship, marriage, divorce, things like that, death in the family, birth of a child, moving, change in job, change in substantial income, things that factor into that overall kind of stress bathtub that keeps getting filled up. Anything in there can cause you to have an LS flare. Likewise, but once again, jumping over to menstruation, we know that there is a change in pain tolerance. We know that estradiol levels specifically have a serotonin effect in the brain. And so as estradiol levels go down prior to menstruation, serotonin levels can also fall. And that can make patients a lot more likely to feel stress, to feel higher anxiety, higher depression. And that in turn can lead to that LS flare. And then other things outside of those, maybe there's these kind of what are called environmental factors. Maybe it's something in your diet. You didn't know that you had a gluten sensitivity, for instance, and now you ate something that had lots of gluten and that caused a flare. Or maybe you started on a new medication and that changed stuff in your gut, microbiome or things like that, and that caused a flare. So there's not an exhaustive list of flare, etiologies or things that cause them, but pretty much the underlying theme is that if it changes the status quo for your life, that can be something that causes that flare. So anyway, there's kind of a little bit of a base overview, if you will, of all of those things. Now, we talk about symptoms, these typical big flare symptoms. I have called these the 4 P's of LS symptoms. We have pruritus, which is a medical term for itching. We have pain. We have our peeing, which is our dysuria, and then painful penetration, or things related to sexual activity or just penetrative activity just in general. So first of all, when it comes to itching, which for most patients is either kind of the first symptom they have of LS or one of their most bothersome symptoms, it's always a good idea to talk about, first of all, why are you having this itching and what's the flare that is causing this? So we know that with itching itself, there are 2 different things that are really causing that itch, if you will, to happen. So in our peripheral nervous system, we have these things called C fibers located in our skin. And then we also have these C fibers that are in our spinal column too. And if something goes along and causes those C fibers to trigger, that is going to send a signal up to our brain. And it will initially translate that signal into an itch. Now, itching and pain are in the same kind of fiber pathway, if you will. And there are things that can kind of exacerbate that nerve signal that translates it more for an itch to actual painful stimuli. If you think about it, as wound heals, if a wound, you get a cut, a lot of times people will say, well, as it's healing, I got the scab on here, man, it's really itching as it's healing. Well, there's still some of that pain activity going on in those C fibers, and it's translating to your brain to say, hey, this is going to be an itch there. Now you can get sensitization, and this is something that we see where we have more of that kind of chronic itch that then leads to the development of more chronic pain. And these are due to the presence of what are called nociceptors. And nociceptors are basically pain receptors there. And the more of an aggravating symptom is present, the more these nociceptors can form. And we see this in a condition called neuroproliferative vestibulitis in kind of the sexual medicine world, where patients may have had initially an itch in their vestibule due to something like a yeast infection or something along those lines. And it causes this kind of cascade and trigger, and it recruits all these pain receptors to pop up. And then that itch turns into more of a pain. So it's all kind of this interrelated thing with itching. And itching, like I said before, is the first kind of symptom of pain. So with that, what can you do to address these itches? Well, so if you're in the midst of a lichen sclerosus flare, the first thing you want to try and figure out is, okay, where is this itch occurring? Is this in a area that I know I have LS? If you have it predominantly in your perineum, for instance, are you having a lot of itching there? Or is this a different area than what you're used to feeling? So obviously we can do things where we have these kind of anti-itch solutions. Something like emollients is going to try and keep the tissue well moisturized. And this can be something like Vaseline. It can be a coconut oil. People have used Aquaphor. I've had patients use A&D ointment, Desitin diaper rash ointment. It's a variety of different things, that's basically going in and providing a topical barrier to that tissue to hopefully calm down that itch response. Now, you can do things that affect kind of the environment of the tissue. So heat is a big thing. We know that a lot of patients will experience worsening vulvar pruritus, especially in summer months. So, things, if they're wearing pants, things are getting more hot. They may be sweating more. That can lead to more itching. So doing things to control that heat, whether that's using cooling fans, whether that's instead of wearing pants, you're wearing a dress, things like that, that could be helpful. If you know that there are certain foods that trigger those itches, and maybe that there in turn triggers a flare, avoiding those foods can be really beneficial. So like I talked about before, gluten is a really known or very kind of well-known trigger of autoimmune issues. If you look into the kind of concept of what's called a leaky gut, and that's kind of in the air, something that is floating around in kind of the fringe of modern medicine, that some people are starting to say, hey, there's really something there, where other people you may go to say, oh, I don't really believe in that. But the more we learn about it, the more we know about how what we eat goes and kind of affects every cell in our body, the more that kind of makes sense. So if you're eating something that is going to irritate you, well, that may be kind of something to avoid, and therefore you can help avoid those flares. Obviously, if that itch is occurring and you're not wanting to use a topical medication, there are certain what are called contemporary alternative medications or CAM therapies that you can use. Herbal antipruritic agents like licorice, chickweed, lavender, yarrow, calendula. Those can be put into like a paste or even applied in the form of an essential oil with certain things like the lavender that may help with the symptom relief with that flare. Obviously, we have lots of anti-itch medications, everything from our over-the-counter antihistamines like your diphenhydramine or Benadryl. You can get hydrocortisone, kind of a low-potency steroid, over-the-counter, or even calamine lotion. It's this bright pink kind of stuff. And then there's our topical steroids too. The mainstay, as many of you know, in terms of lichen sclerosus treatments are going to be our ultra-potent steroids. And typically we're going to want to use those in an ointment form just to help them get and penetrate that skin really well. But those can be helpful in addressing that itch. And then you're in a flare, you may have to increase the frequency of your steroid application. So if you're on a maintenance dosing, using it, twice a week or so, well, maybe you go to every other day or maybe even back to once a day for that steroid application. Obviously, if that's not working or you're getting in really substantial flares or having things outside of just the vulva, more oral or even intramuscular injections of antihistamines or steroids may be done. And this can be everything from different dexamethazones or prednisone injections for the IM stuff, or prednisone oral, Singulair, which is an oral type of leukotriene inhibitor that can influence itching. So different ways to kind of go around and treat that flare in the itching that you may have. Now, this is something just to kind of think about, when you're thinking about itching, and maybe can help you resist that urge, because we all know that is a huge thing when we itch. Here's kind of our itch scratch diagram, and we get our itching over there on the left, and our body says, hey, you got an itch, you got to scratch it. So you go and you scratch it, and maybe once or twice you're like, oh, that feels kind of good. But then you do it again, over and over again, and oops, now you're going to get some damage to the skin barrier, and that can cause everything from just localized infection in worst case scenario to just the introduction of different irritants into the skin, which in turn causes irritation, which in turn causes more itching. So that's one of the things that when you're talking about an itch flare, if you will, something to consider. And this sounds kind of silly, but we'll often have patients wear gloves, especially, or mittens, actually even more so, when they sleep. When we're awake, most people can do a fairly good job of controlling that itching urge. But if it's present during the day, it's going to be present at night too. And oftentimes, as you may know, it's worse at night. And so doing something that can prevent those lovely fingernails that you have from scratching the skin can be really helpful in breaking that itch scratch cycle. So putting mittens on while you sleep, even though it's can be kind of silly. Although I guess it's winter time or getting close to winter, so that may not be that bad. You can have matching mittens and a stocking cap for your night before Christmas or whatever you want to do. So anyway, here we go. Our next thing is going to be going from itch to pain. So late great Betty White, people say gross and balls are weak and sensitive. You get tough, grow a vagina. Those things take a pounding. I love that quote for her. So, but anyway, pain by itself is really interesting, from a purely neuroscientific standpoint, like what actually is pain? Why do we feel pain? So the official definition, pain is a distressing feeling often caused by intense or damaging stimuli, and our body has, evolved to have pain to keep us out of dangerous situations. You think about it, if something hurts, we don't really want to do it, and you learn through this kind of process called neuroplasticity that doing that painful activity, whatever it may be, will hopefully keep you from doing it in the future. I've often used the example, I don't want to shut my hand in a car door because I know it's going to hurt. Same type of thing. Well, in developed countries, pain is the most common reason for physician consultation. Kind of interesting there. We know that it interferes with quality of life and activities of daily living. Literally, pain can end up running people's lives, and everything they do is based around how much something hurts if they're dealing with it. And so there it interferes with everything you do or want to do. And so if your flare symptom is pain, that's a really horrible thing. If you're the type of person that's normally active, doing things, going out with people, you may find yourself, bedbound because it just hurts so bad to get up and move around. So from a neuroscientific standpoint, once again, this is what's really going on with pain. We've got kind of our two different fibers that are translating pain. We've got our alpha delta fibers there and our C fibers. Now, these are going to have different types of pain. One is going to be more of our sharp, stabbing type pain. The other is going to be our kind of dull, achy, you just slammed your knee against a table leg type of pain. But regardless, when that happens, those fibers get compressed. They send a message to the dorsal root ganglion that's lying outside of our spinal cord. Then that goes in and it goes up the spinothalamic tract, the lateral spinothalamic tract to be exact, up into our brain until it goes to our portion of our brain that's kind of regulating not only what we're doing in response to the pain, but also in how we are learning from that. And so that's where you see things like in the thalamus or the ventral posterior lateral nucleus, where you see kind of people acting in response to pain and learning reactions to that discomfort. This also plays a role too in a reflex arc too. If you put your hand on a hot stove, you don't have to think, oh my gosh, that's hot. That's because you do get this kind of reverse loop down there in when you get to the dorsal root ganglion that says, hey, pull that hand away from that stove. So how do we treat this? Now we've learned about it. When you're in a flare, what can you do to help deal with this pain? So obviously we have kind of three different ways of looking at this. You have stuff from the site itself. If you have a cut on your vulva because your LS has flared and now you have been scratching it and you have this excoriation and it's created what's called a fissure there, okay, that can be really painful, especially if it's on an area that where you have other irritants that are normally contacting it. The most common one we'd see is something either around the urethra or on the perineum. And so urine, which is naturally acidic, every time you urinate, that goes and it stings or it burns that tissue and can cause lots of discomfort. So for that, obviously, we have our topical steroid creams, and we can also use topical pain medication too. This would be something like your lidocaine, viscous lidocaine gel or something along those lines that you can apply directly to that site that will soak through the skin and kind of help inhibit that painful sensation. Now, you can also inject that site too with that same type of medication, whether it's a steroid or an analgesic. And that can be pain medication that's going to block the pain itself, or even a kind of injection of a more broad range pain medication, like if you had an IV and you gave someone morphine. Well, that's definitely going to help that. Maybe a little bit excessive, but sometimes flares can be really horrible. Now, obviously, something that we do know that goes in line with LS is that patients can develop, especially if they have it on their clitoris, lots of adhesions connecting the glands of the clitoris to the hood of the clitoris. You can get debris trapped under there and form these things called keratin pearls, and that can feel like getting a grain of sand stuck in your eye. And so going in and lysing or breaking down those adhesions, getting rid of that debris can be very helpful for reducing clitoral pain. Some patients will also develop what are called granulomas, which are like collections of scar tissue, if you will. They may cause pain, especially if they have one of those peripheral nerves kind of embedded in them. And so removing that granuloma can be helpful in reducing pain too. That's going to be someone that, not necessarily in a flare, you're going to notice that, but it may be something that you can tell, hey, that's usually there. And when I'm in my flare, it's a lot worse. Now, kind of going more into a regional thing, if you say, hey, this flare is causing compromise of my entire right side of my vulva, for instance, is there something where you could potentially do a regional type of pain control? So that's going to be something like a nerve block, whether that's something in the pudendal nerve, which is the main nerve that causes sensation to the external genitalia, perineum, and area around the anus, or something a little bit higher up that's into the hypogastric plexus. That's a collection of nerves, and that also has a autonomic effect to it too. And the autonomic nervous system is kind of our uncontrolled nervous system, if you will. Two main types are fight or flight or sympathetic nervous system, and our rest and digest, which is our parasympathetic. And that hypogastric plexus blocks can be helpful for patients that are constantly in that kind of heightened, agitated, wired state because they're hurting so much. Now, sometimes regional blocks can be helpful, but they keep coming back, especially if you have a long flare. And so doing something to actually cause the nerve to be ablated to where it's not sensing things anymore, whether that's a kind of quote unquote hot ablation or a cold ablation, to where you get rid of the nerve so you don't have the pain fibers getting transmitted, could be useful. And likewise for patients who have chronic pelvic pain, even in acute flares, doing things like pelvic floor physical therapy can be beneficial, because we know that the pelvic floor will often spasm as well as a protective mechanism when you have genital discomfort. Now, obviously, if none of these things are working, something you may want to consider is kind of doing kind of more central pain reduction techniques. So whether that's pain medication specifically, psychotherapy focusing on kind of pain psychology, looking at that, or these what are called surgical nerve stimulators. And these are implanted either in your spine or on the dorsal root ganglion. That's a DRG stimulator. And they basically act kind of like a TENS unit, if you've ever had one of those or used one of those, where they provide an interfering signal to that nerve so that your brain focuses on that. And it's more of a mild tapping, if you will, versus that sharp searing, discomfort that may be present when you're in the midst of a flare. So there are different ways you can treat that flare-related pain. Now, obviously, pain has, especially in the United States, has gotten a bad rap. It's very difficult from a provider standpoint to, if you have patients who are in chronic pain, there's a lot of hoops you have to jump through. And some providers don't prescribe pain medication at all because of that. So it's something that, you want to think about. When do I do something about it? Some patients will have a lot of anxiety, if you will, about talking to their healthcare providers about pain itself. So remember, pain is completely subjective. No one can tell you don't hurt. And it's something that if it's interfering with your normal daily activities of daily living, that's at ADL, it's time to act on that. If pain is keeping you from living your best life, yep, it's time to act then. And then obviously there are patients, and we see this, not only in kind of pelvic pain in general, but even in very specific conditions like LS, that their symptoms get bad enough that they contemplate hurting themselves or ending their life. And so if that's the case, please reach out to someone you trust, family, friend, or even online support group. There is hope out there for you to help kind of get through that flare. Because remember, that's the thing with flares, they are temporary. They will get better. It's just a matter of identifying what caused that and addressing that specific thing. So here's our painful peeing, otherwise known as dysuria. And when I said when it hurts to pee, you're in trouble, I found this funny little thing. Please urinate with precision and elegance. Very mindful, very demure urination. So anyway, so dysuria is a very arcing medical term. Basically, it means discomfort with urination. And that can be whether it actually has pain or you have more of an urgency. You're having an abnormal sensation of pain. And with patients with lichen sclerosus, often if they're getting a flare that's really involving their urinary tract, or they're having an increased sense of dysuria, typically they're getting some referred issues from that skin discomfort that's getting and affecting actually kind of the pelvic floor too. So anyway, there are multiple causes of dysuria. Obviously, infections and urinary tract infections are the most common ones that people think about. And I can't tell you the number of patients that have come in over the course of my career and say, hey, I have a urinary tract infection, and you test their urine and they don't. And half of these people have been put on antibiotics multiple times without ever having the urine tested. And that's a little pet peeve of mine. But just because it's not a urinary tract infection does not mean there's something wrong. It just means it's not an infection. So there are inflammatory bladder disorders, interstitial cystitis being kind of the main one we see with that. And then you can get referred pain to the bladder, to the urethra, to the urethral trigone, kind of where the muscles constrict around the urethra. And whether that's from a fissure, we see that very often with lichen sclerosus, probably the most common thing that we'd see, where the skin is cracked, or from vestibulitis, tissue of the vestibule, the entrance of the vagina can be inflamed, and the urethra exits out through the vestibule, and or pelvic floor dysfunction, as the muscles around the bladder are so spasmed they make you feel like you have to pee a lot more than you actually do. So how can we treat it? So obviously we're talking about infection specifically, but if it's something more inflammatory, and this is what, if you were to do what's called a cystoscopy, putting a little scope in the bladder, these are things we would see with interstitial cystitis, these kind of increased, or what are called Holler's ulcers and trabeculations. That can be managed with specific diets that are low in oxalates, low in acidic foods. Some supplements can help with bladder issues, and then different medications too. Obviously, if it's more of a referred issue, there's our lovely clobetasol that many people are aware of. If it's the vestibule, maybe this is something that's related to the hormones. If patients are on oral contraceptive pills, or even if they're menopausal, addressing hormonal deprivation can be really helpful. Steroids, obviously, once again, for those fissures. And then doing things like pelvic floor PT or even Botox, like I mentioned before, to try and get those muscles to relax and allow the bladder to calm down. Now, Here's my little pet peeve about dysuria. Does that equal a urinary tract infection? I reuse this Shakespeare quote. I realize, I don't know why. I'm not like a huge Shakespeare person, but I mean, it's it's a cool quote, I guess. Anyway, vestibular irritation. So remember, the vestibule is the tissue at the entrance of the vagina. That's where the urethra comes out. Irritation will mimic urinary tract infection symptoms. Likewise, pelvic floor dysfunction mimics urinary tract infection symptoms. So if you think you're like, oh my gosh, I'm having an LS flare, I think I have a UTI as well, please, please, please go get a urine analysis done. Go leave a urine sample in a little cup. You can even do it at home nowadays and see, is there really something here that is infectious? So the other thing we have to talk about, especially with kind of urinary frequency, are what are called neurogenic dysurias. So when the bladder senses tightness, and this is really what we see with pelvic floor dysfunction, it relays that pressure to the brain, and the brain then says, oh, hey, we are stretched to capacity, much like a balloon that's fully blown up. We need to empty the bladder. Now, we are able to potty train, right? When you were a little bitty, kiddo, maybe you had to go to the bathroom every hour when your parents were trying to potty train you. They sat you on the toilet. If you went, great, you got an M&M or a Cheerio or something. If you didn't, that's fine. They take you off. They do it again until you learn over and over and over to hold your urine longer and longer and longer. Well, as we get older, people, for whatever reason, we tend to like to reverse that habit. And as many of us are getting up in the middle of the night, because that's what happens, it seems like, when you turn 40, you may say, well, I'm up already, I might as well pee. Well, the more you do that, the more you're training your brain to say, hey, I should go to the bathroom when I'm at this capacity of bladder fillage, if you will. Not when I'm at my full capacity, like, oh my gosh, I need to pee. And so as time goes by, your brain starts to learn, oh my gosh, we're at 50% capacity. Better tell so-and-so it's time to go to the bathroom and you need to pee. And that can get worse. I mean, I've had patients in here that when they're on LS flares or having LS flares, they may pee every hour on the hour. It's not because there's an infection or they really need to go from your bladder's going to explode standpoint. It's literally that they have trained their bladder so much because of that pelvic pressure. I need to relieve it now. And so when it gets that little bit of filling inside of it, it tells your brain, hey, time to send out that urge to urinate. And so then that's what happens. So you can retrain your bladder with time. It's difficult, but you can do it. And that can be really helpful when you're in the midst of these LS flares. If dysuria is your main symptom, do some deep belly breathing, really try and relax that pelvic floor as much as you can. And you may notice that urge to urinate goes away or at least gets better and more tolerable. So our last thing is going to be our painful penetration here. Maybe it's not good enough reason to use the word penetrate. I don't know. But we're going to talk about it anyway. So why does penetration hurt? So this is kind of a waterfall effect here. So initially, you may have tissue that's being stretched. Maybe you've got a fissure on your vulva. Maybe you've got an area that's excoriated, scratched, and that doesn't feel very good. And so what that does, it says, ooh, I don't like that. Well, if you keep trying to do it, then you're going to get these nerve effects going and firing back to your spinal cord and saying, hey, this is hurting over and over and over again. And the more that you do that, your body tries to kind of protect yourself because that's what the body likes to do. And it says, hey, you know what? We need to keep things on lockdown. When we hurt, it is the body's natural tendency to isolate or contract the muscles around the area that's hurting. If you think about it, if you pull your shoulder, let's say, out of socket, throwing a softball or something, well, afterwards, those muscles can spasm as they try and hold things in. Same type of thing in your pelvis, especially around your genitalia. And over time, this kind of chronic pain effect, that pain relation, if you remember back to that pain slide, tells your brain, hey, any time that we're going to have penetration occur, that's going to hurt. Even if you take away the thing that causes the pain, the brain still remembers. And so you have to retrain your brain. If you're out of that flare and you're like, oh, actually, hey, this shouldn't be hurting, My skin feels good. I'm not really feeling anything bad. Hey, it's okay to try and have penetration. It's not going to hurt anymore. And that can be a long process too. So, how do we treat that painful penetration? So, kind of going down that kind of waterfall. Obviously, we're looking first at those local effects, medication being kind of the a first line therapy for some patients, whether that's going to be their steroid, whether that's going to be an anti, like a topical lidocaine, whether it's going to be just putting heat kind of on that tissue to try and help desensitize it. Obviously, if you have an area that, the brain is kind of has been hardwired after many years to think this is hurt, doing dilator therapy can be really helpful because that dilator touches that tissue and tells your brain, hey, this is a very innocuous, harmless thing. We can let this touch this tissue. It's not going to hurt. It's okay. And the more you do that, the more you can retrain your brain to think, hey, that's really helpful. For certain patients, doing a trigger point injection, doing a local pain injection, or even surgically removing like a granuloma, or if they have those keratin pearls, that can be really helpful with treating that local pain. Obviously, if it's in the nerve is the kind of the issue, biofeedback to try and retrain your brain around how those nerves are firing can be helpful. Using neural modulating medication, something like gabapentin or Lyrica, some of you may have heard of before, can be helpful. Or even doing nerve blocks to try and help with kind of the, calm down the nerve itself. Now, obviously, regional things, this is where pelvic floor physical therapy really comes into play. Maybe we're also doing muscle relaxers in the form of a vaginal suppository or pain medication in the form of vaginal suppository that's really just going to hit the pelvis there. Likewise, you can be doing injections into those pelvic floor muscles with things like Botox, or even doing kind of more regional steroid injections too if you have a lot of bad trigger points. And then obviously, if this is something that's gotten up to the brain level, we need to desensitize it up there. We need to work with our psychotherapy colleagues to try and get that brain to say, hey, penetration is okay. Now that we've gotten the flare calmed down, we can resume that normal activity if you want to. So obviously, here's a question. Does painful penetration mean LS? No, it doesn't, but they do often go hand in hand. It can lead to painful penetration, but it doesn't have to, especially if you're good at maintaining and controlling those main symptoms. And when you have flares, recognizing, hey, this is a flare, it's going to get better, we can work through this. There won't necessarily have to be the long-term psychological effects. So, in kind of a recap of our 4 Ps, obviously, if it's just an itch, if that's your main kind of flare symptom, figure out what's going on. Is this something that's related to a local spot? Is it peripheral? Or is it more that you've kind of sensitized things and you need to do something kind of more with that central itching? That's where something taken like an antihistamine may come in place. Start off using emollients or environmental changes, getting out of those pants into something more like a skirt or a kilt. If you're a guy with lichen sclerosus, you can rock your kilt. And then don't be afraid of topical medications, especially those ultrapotent steroids, which done and used correctly, there's our little caveat, are the gold standard for LS in managing both chronic conditions and flares. If pain is your thing, remember, hey, that's okay. Like, your pain is valid. We want to try and treat this, and we can use from a local or a regional or even more kind of central therapy, and often doing multiple things together works the best. If your symptoms with your flare are more of a dysuria or a painful urination, it may be a urinary tract infection, but more often than not, unfortunately, it's not that. So we want to kind of see what it is, really go and investigate what's going on. Is it related to, that urine burning, causing a burning when it touches a fissure or something? Is there more of a pelvic floor thing? Treat the underlying issue. And if your big thing is that painful penetration, if that's your main symptom with flare, kind of go down that pathway. What's going on the local level? What's going on the nerve level? What's going on regionally in my pelvis and up in my brain? Treat according to that source. And remember, the painful penetration may not be from LS specifically, but can be a reaction to the LS flare itself. So how do you manage the flare then? That's another question, right? Well, stress management, if this is something that there's going to be some stressful things in your life, it's the holiday season, that's a time of stress for people. So being mindful of that, giving yourself grace to say, hey, it's okay if my I'm a terrible gift wrapper. I have come to embrace my horrible gift wrapping, and I try and make it as bad as I can because now it's like an art form. It's like gift origami. If you need to see counseling or therapy, that's okay. That does not mean by any means you are a weak person or can't handle things. No, nothing at all like that. We all deserve to have a third party person that we can talk to that can help us get through those things. Proper diet, if you know that dietary triggers are your big things, okay, we're going to try to figure that out. Maybe you need to see a nutritionist, to figure out things. Make sure you're hydrated too, folks. A lot of people don't drink enough water. I'm one of them. Drink a lot of water. That can be really helpful there for you. You may want to consider supplements too. Those can always be helpful to help if you're missing nutrients from things. Obviously, immune support. Once again, it's cold and flu season. Make sure you're washing your hands, doing things to stay away from getting sick as best you can. If you are a menstruating person, it's going to happen. But maybe pads are causing you issues. So don't use a pad. Maybe you're a tampon type of person. Maybe you're not a tampon type of person and you want to use a menstrual cup or a menstrual disc. There's a bunch of different options. Or nowadays they have these wonderful underwear that you can just free bleed in, and that is totally fine. And that can be really helpful for reducing those symptoms. And then finally, if it is something environmental, maybe it's something, consider changing your, laundry detergent. If you have other allergies, related to ragweed or something like that, try an oral antihistamine, see if that helps stuff. And if this has been helpful for you and you think that my form of talking is maybe helpful and you'd like to schedule an appointment or just give us a call, there's how to reach us here at Haven Center. There's our website or a phone call, and we are happy to talk with you across the country and across the world. So that's what I have for you with my slideshow. Back to you, Kathy.
Thank you so much. If I can get there it is. This was awesome. I love you, Dr. Babb. You make everything so like you go into the science, but you make it easy to understand, which is really cool.
Thank you.
So we are starting to get some questions here.
Okay,
so
great.
I'm gonna go ahead and pop some of them up.
Yeah.
Here's our first one.
Okay, so how long is a long flare? I had one summer that for 4 months. Is that long? That is a long flare, yes. There is not, unfortunately, a good, kind of, this is a short flare, this is a medium flare, this is a long flare. You kind of get into these almost arbitrary, word choices. Honestly, if it's a flare, even if it's for a week, it still can be impactful for what you're doing. And so my suggestion with that, and I know you didn't ask that in the question, but if you are having a flare, I would get on top of it as soon as you start flaring. Honestly, like that's going to be something where you're going to hopefully get to the point where you may not last, have it last for the 4 months there. So if having UTI symptoms but your analysis is negative, how should the attending doctor proceed with treatment? Should you see a urologist? So that's a great question. So what we will typically do if we have a patient who has UTI symptoms, but that like kind of dipstick urine is negative, we'll send it for culture. That's a cheap and effective test to know, is there really something bacterially going on here? Because remember, when you look at a urine analysis strip, there are typically two things that people will say, oh, yes, this is a UTI or not. One is the presence of what are called nitrites, which are byproducts of certain types of bacterial reproduction. The other thing is there the presence of white blood cells or what are called leukocytes in your urine? So you can have someone who has a negative nitrite, but still has specific pathogens or bad bacteria that are causing an infection. So that's why I typically say, hey, go to urology or go, send a urine culture there. Now, the other thing, if you go through that kind of checklist, hey, is my pelvic floor, is something hormonal, and you're still having just chronic dysuria, that painful urination or abnormal urine sensation, that's a pretty good idea to see a urologist. That's when you'd want to kind of seek out that specialty help. Yep.
Awesome. And I am being a very bad fundraiser. You guys, that was an amazing presentation. And We want to make sure that Dr. Babb comes back often. So if you haven't donated, please do think of hit that button. It says donate/tickets if you're on our Give Better page. And every donation is doubled right now. So $25, it makes it 50. And we just I'm going to announce this. This won't be official until tomorrow, but you guys get it first. Every donation over $100 is going to get the best of the Holistic Healing Summit replays. So we have a playlist of 26 past sessions because why not? You guys are awesome. We want to support you. And we're talking about all kinds of things. So if you like Dr. Babb, we've got a whole 45-minute, another 45-minute Q&A with him on there. We've got all kinds of talks with all the kinds of experts on everything LS related, from food to sex to pelvic floor, you name it, we've got it. And it's all in that. You just need a $100 donation or more. And I want to start shouting out names. So as you're dropping your questions, I want to start seeing the donations come in. All right, next question.
So how might those nerve blocks that impact the autonomic nervous system impact a patient with dysautonomia? There's the cough. Thank you for discussing that, because this is something we are seeing so much now. Like, I can't tell you the number of patients we see in the office with dysautonomia. So the hypogastric plexus block, you may get some correlation with down-regulating that over what's called adrenergic activity, or that fight or flight response. The pudendal block is not going to do that. The pudendal nerve by itself is just a sensory nerve. It doesn't really have other autonomic things, but the hypogastric plexus does. So that is something that, if someone, like I said, is really also kind of ramped up, has a lot of that fight or flight type response, they may benefit from that as a way to control their pain. Now, you want to find someone that does a lot of, in that case, hypogastric plexus blocks. I have a person who I send I have two people that I refer all of my big kind of pain blocks to. One guy is in Atlanta, John Vogel, and the second one is Arun Kalava in Tampa. Those are my big kind of block people that do all the complicated blocks when I refer patients to. So
when you're writing your guys' questions in, please make them general. Dr. Babb cannot give individual medical advice. So if your question is written with your medical story and you're asking a question, I will reword it to make it general, so we don't have any trouble here. Okay.
Yeah. Clobetasol, a couple years, noticed a lot of new brown freckles. So yes, so you can get this kind of what's called melanosis, which is what we see with chronic steroid use. It's completely benign, nothing to be concerned about with that from a medical standpoint. Obviously, from a cosmetic standpoint, if you don't like it, there's not a ton we can do other than, I guess you could do like some skin whitening type things. But it's just a reaction to the steroid. We see it fairly frequently, honestly.
The post-inflammatory hyperpigmentation. Oh, okay.
Cool. Yep, you got it.
All right, next question is, any particular supplements in relation to
that's a great question. So depending on there's not obviously a straight like LS supplement thing, but if you think about what LS is affecting, you're looking at the skin, so you can do things that affect collagen. So whether that's going to be actual collagen supplementation, you can use things like biotin sometimes could be kind of helpful if you're talking about kind of skin elasticity. Things that can help with immune function, turmeric, vitamin C, zinc, those are all things that you could consider. It's really like if you go and you look for anti-inflammatory supplements, those are probably going to be the biggest things. That in skin health are going to be the biggest things that you can see with a potential LS benefit. But like I said, not anything that is a definite, yes, we know this is a huge, you know, good treatment option for patients with LS to be on this type of supplement.
All right, I'm going to reword this next question. If you've been on a treatment for every day with your clobetasol or your steroid schedule, and you never seem to be able to step down, do you have any suggestions?
Yeah, so now obviously that ultra potent steroid, whether that's clobetasol, halobetasol, betamethasone, whatever it is the gold standard treatment for preventing skin cancer. So there are a couple things that you want to consider. First of all, you may want to try and switch up to a different type of ultra potent steroid because some people just don't react as well to one they do to another. I typically will switch families. So if they've been on clobetasol, I'll instead put them on betamethasone. The other thing you can do, especially if you're perimenopausal or postmenopausal or nursing, or if this is a pediatric patient, something to consider as well, would be to add a topical estrogen. That can sometimes be kind of the difference in helping the skin heal really well. The third thing, and this is kind of getting into secondary therapies that may just help with healing, is where you're adding some of the what are called calcineurin inhibitors like tacrolimus or pacrolimus. Some people may benefit from that. They just do not have the same reduction in squamous cell carcinoma that the steroids do. We will also sometimes, for patients who have recalcitrant LS, if they're doing all those things, we'll do platelet-rich plasma injections into the lesions themselves. That is something that the data is kind of mixed about. We have found it to be helpful, but once again, it is an adjunct therapy to help kind of, in that case, go from someone who's having to do therapy daily to backing off to every other day versus an actual treatment itself for the condition. So those are some things to consider. Okay. So besides treating with clobetasol and topical hormones like estrogens and testosterone, what will be done to help with the architectural changes, reabsorption? Are there procedures or treatments to address it? So the short answer are there are things out there that some people have used. Are they considered like the definitive gold standard for architectural changes? No. But this is where you're getting into some of the kind of things like platelet-rich plasma. I've seen some people show pretty impressive results using radio frequency kind of, treatments, lasers, things like that. It's really a mixed bag, though. You just have to, be cautious and go to someone who does a lot of this for LS patients. I wouldn't go to, like, no offense, but some of the places that are like, oh, we do the, PRP for, facial rejuvenation, and say, oh, let me try and do that on your vulva if you're an LS patient. So, but those are where you're going to see some of those kind of patients who will say, yes, this really helped. You will also see people that say, I didn't do anything. So it's your mileage may vary. Is it common for LS to present with loss of subcutaneous fat affecting tissue at deeper layer below the skin? Oh, okay. So, I mean, in severe LS, you are going to see that flattening. The other thing you would also want to make sure too, especially if this is in a perimenopausal or postmenopausal patient, you're not also seeing the LS in conjunction with something like genitourinary syndrome of menopause, which will typically cause a flattening or loss of that subcutaneous, fat layer as part of that, condition too. So that would be my thought with that. Obviously, there are other things that look like LS that affect the vulva that are not LS. Extramammary Paget's disease, for instance, that can sometimes show up like that. We've seen vulvar Crohn's that has been mistaken for LS that affect those other tissue layers as well. So, if things aren't responding, that would be an indication to get a biopsy to say, hey, let's make sure there's nothing else kind of going on with this too. Does eating a low oxalate diet help us figures or help keep LS more under control? A lot of people say it does. And that is, once again, your mileage may vary. You get into the realm of nutritional or kind of dietary inflammatory, modulators. And obviously, if you're reducing those, that can be really helpful in reducing your symptoms or your flares. Does menopause affect LS? Yes. Are there hormones or treatments that vary from menopausal state? So for a lot of patients, like I said, if you are menopausal and you have LS, or really if you're menopausal just in general, there really is very, very little reason to not be on a vaginal estrogen. The health benefits for vaginal estrogen therapy in menopausal patients so far outweigh the risks associated with it that for most, I mean, that's kind of going to be the standard of care here as we kind of, over the next few years. So to answer your question, 100%, we will often put patients who are menopausal, who have LS, if they're doing once a day clobetasol, for instance, we'll have them do their clobetasol in the morning and do a topical estradiol at night 2 to 3 times a week, depending on what's going on. Or if it's really severe in the midst of a flare, for instance, even nightly for that. You can do topical testosterone too to different parts of the vulva. That can sometimes be helpful. But estradiol for the menopausal patient is often the balm they need to really see a good reduction in their symptoms. What if your flares don't have itch or pain, but only visible sign changes like hypopigmentation or redness? So no, that can be a flare too. Remember, kind of talking about what a flare is, it's kind of a worsening of your normal, symptoms or signs. So yes, you can see, especially if you notice that something goes on to where, you get respiratory illness and, oh my gosh, I'm seeing a lot more redness, a lot more irritation, a lot more things. Yeah, that can be a flare too. And so you want to kind of go and start to treat that, even if you're not getting kind of that clinical symptom like the itching or burning or things along those lines. Eczema, could this be possible onset? That's a great question. So eczema as there's a thing that's called lichen simplex. So remember lichen sclerosus, we also have lichen planus, these lichenifying disorders of the vulva, which can result in a thickening of the skin, much like lichen on a tree. Lichen simplex used to be called and it sometimes can be called neurogenerative I just totally blanked on the word. It's basically a neurovulvitis where the nerves are really agitated, so it causes that itching. So eczema has a same type of presentation outside of the body too. And so yes, there is kind of a thought that if you have eczema already or had it as a child, you may be prone to develop LS later in your life. And those same things that you use to treat eczema can be used to treat LS too. So, a lot of people won't do clobetasol, although you can for eczema, but you can use it for that. Dupixent, which is a new type of medication for eczema, there have been some clinical trials that have shown some really good promise with LS for that in treating that too. So yes, you can treat them in a similar way, and they do have some connection going back to the actual underlying skin change. So like I said, so the PRP, I'll talk on that first. We do PRP injections, like I said before, as adjunct treatment for lichen sclerosus. It is not primary therapy. It is more to address symptoms and to help kind of the treatment that we're doing kind of work better, because it's helping kind of with tissue turnover and healing. Borax for me is not something that I typically recommend. I know there are patients that swear by it. It's just not something that I have seen. When I think about the treatments for LS, the biggest thing that I want to prevent is the development of skin cancer. And I know that's extreme, and we can talk about how the percentage is low. But, I had a patient in my own practice here recently that was seen by another provider that came in and did have skin cancer. She had been, treated in a way that was not kind of the standard, of care. So I want to, that is always my main thing. And I have, much like even with calcineurin inhibitors, which are considered second-line therapy for LS, they don't show that reduction in skin cancer. So I always want to have that as my main treatment option. So that's why I tend to, I'm not one that recommends borax, because I don't have the same data that I have for that I have for other different therapies. High rates of dysautonomia and correlation with hypermobility Yes. Okay. um, so obviously the hypermobility, EDS, MCAS, dysautonomia, those are all in this lovely circle that goes together. Can the LS losses be confused with hypermobility stuff? So from a tissue histology level, if you're taking a tissue sample and you're looking at it under a microscope, some of the things that we see with LS specifically, we are not going to see in hypermobility patients if you were to do a tissue biopsy of them. So from that standpoint, no, that's not something that you'd see. Now, if you're talking about symptoms, obviously patients who have connective tissue disorders may have very velvety skin that easily tears, that is scratched and can be irritated. If they have MCAS, okay, maybe they have a heightened sensitivity to things, and that's causing that itching or burning. And so the symptoms can definitely mimic each other. But that is, once again, and I haven't talked about it with this kind of discussion, but Kathy knows I usually harp about this. The way to really diagnose LS is with that tissue biopsy. And so that's where you're going to have a patient that you're going to say, aha, this issue right now that I'm biopsying, this is lichen sclerosus versus whatever else it may be. Often get checked for cancer in that area. I mean, we do for our LS patients, we do 2-month regimens. So if they come in, if it's a new onset, new diagnosis, we'll put them on daily clobetasol typically. We'll see them back in 2 months. If things are looking good, they're symptom free, we're not seeing any signs of active disease, we'll switch them to every other day for 2 months, come back in. If they're still looking good, they go to twice a week, kind of maintenance dosing. And some of those may try once a week if they really are good. Once we get to that kind of maintenance dosing, we're seeing them every 6 months. So that's when we're doing actual skin evaluations. We're looking. So that's my protocol. Obviously, I'm a little bit biased because we see lots of LS patients and things. So we're always maybe more hyper vigilant. But I would say at least annually, if not twice a year, are you actually having someone check your vulva and really see, from a professional standpoint. And you should be doing monthly vulvar exams just on your own to look for things. Main symptom of vulvar cancer, honestly, for a lot of patients, it's just that they have a spot that's not healing. The last one that I had, that was her main issue. Basically this one spot that just kept, she was trying the different things, and just wasn't going away, wasn't getting any better. It was bleeding, it was being irritated, things like that. So it's not like an overarching, oh my gosh, this is, here is cancer symptom. It's more of this really isn't changing when we're doing the therapy. So if you're doing surgery on patients with LS, you have to be very careful with it. Obviously, anytime you do surgery, you're going to cause potential scarring. I mean, really, we try and avoid doing surgery on patients with LS unless it's an absolute necessity. I've done one dorsal slit clitoral hood procedure on an LS patient, in the past year. And we tried everything to keep her clitoris from, clitoral hood from fusing. We've done stuff in the office multiple times, things like that. So I am always hesitant if you're going and actually breaking skin down to say, hey, this is a good therapy for it. So I said, that's my kind of, maybe I'm overly cautious, but I would only use those kind of surgical corrections. And that goes with laser too, from my standpoint. Like kind of last resort, you're just not getting a specific effect. Like in that case, that patient was having continual clitoral pain because she kept getting keratin pearls underneath her clitoris just because it kept fusing. So that's why we end up going in and actually, opening things up kind of more of a permanent standpoint.
We're getting a lot of questions on JAK inhibitors.
Yeah.
So if you can talk about that versus other treatments and
that's the new stuff, and that kind of gets into, I mentioned Dupixent. That's the trade name for it. It's kind of something in the new line, but basically JAK inhibitors just in total are working on kind of immune function. And you're seeing patients who are going through trials that are really getting good, reduction in their symptoms with it. Now, these are typically injections. There are other ways to do them too, depending on what you're talking about. But that is in my mind, if I'm kind of thinking ahead, where I bet we will see the majority of LS treatments being geared in the future. The big thing that they're going to have to prove over and over again is, do you see that reduction in skin cancer? The other thing is that they're new medications. They're expensive. Insurance companies don't like to approve them. Clobetasol, betamethasone especially, is pretty cheap. And so that's going to be the other hurdle to get over, to say, hey, LS is a big enough issue that you're going to have an FDA approval for this condition. And we could talk about that soapbox all day long. But that's my thought on those. Oh, a shower routine. What would a shower gels or just with water? So that's a great question. Now, definitely, I do, when you talk about vulvar hygiene, I am not opposed to patients getting some soap or shower gel, especially if it's unscented, on their hands and rubbing it on their vulva, things like that. You do not need to take like a loofah or anything like that and scrub that tissue to town by any means. That's for anybody. Letting especially soapy water kind of run over the tissue can be fine too. Some people will get a lot of cake discharge in the infralabial sulcus, the area between the labia majora and labia minora. And so making sure that area can be clean is a good idea. But once again, you do not need to scrub, very aggressively to keep your vulva clean. But I do think it is a good idea to make sure you're doing some form of hygiene practice, because dirt can get in those little teeny scratches, and the last thing you want is a cellulitis from that. So, but too strong for your skin. So that's a really interesting question. And the idea of skin thinning, you will often hear from patients, or from, patients may tell you this too, but other from providers that are not as familiar with treating LS. Those of us that do this a bunch, I cannot think of a patient who's been on an appropriate steroid regimen that has had skin thinning. Now, and even with the ultra potent steroids. Now, how much you're using, you really only need, I've got a pin here. It's got a little clicker thing. I will tell patients to put about, I don't know if you can see, maybe like that much, this end of the pin here, once it's clicked in, on their finger, kind of like a pea-sized amount there. You can kind of see that there. And if you rub it in really thoroughly, that's the thing with the ointment, it will spread. And doing that once a day even is not, like I said, I have never, knock on wood, had a patient that had skin thinning from that. But typically the skin thinning patients are patients that have been told to use it, 2 or 3, 4 times a day. I had someone recently that was told 3 times a day. And that just isn't, the data doesn't support that. So that would be my kind of thing with that, if you're doing it correctly, there shouldn't be a too strong of a steroid for, especially the labia majora, the thicker, squamous tissue. Like I said in the PowerPoint, that area is meant to take a beating. And so you're not going to see a lot of tissue breakdown with it. The BMs like constipation or diarrhea. You can have it, sure. Obviously, if you have LS and you have kind of resultant pelvic floor dysfunction because of that, because you're always kind of tight through that pelvic floor area, that can definitely contribute to constipation very much. It changes the angle kind of the anus as stool moves through there, and through the rectum, actually more so than the anus itself. But diarrhea from LS, not necessarily from that. Now, other vulvar conditions you definitely can see with having bowel issues, the most common being vulvar Crohn's. You'll often see lots of bowel issues with that. By estrogen for hormonal flares, as long as it takes to see a benefit. So, honestly, I'll tell patients with the estradiol, if they have a cream, apply it all over the vulva. It's really the dosage in that you can't OD on vulvar estrogens. Really, they're such a small dose. So you can apply it really all over the vulva. You can apply it on the areas that are flaring. How long to take effect? You have some patients that if they have not been on any type of vulvar estrogen, you start them on it and they may notice changes within, a couple of weeks. Obviously, if you're doing it already and now you're increasing the rate with you're doing it, due to a flare, you may, notice something sooner than that. But hormonal stuff takes a while to build up in the tissue. So typically, if you're starting from scratch, we tell patients to expect around 6 weeks before they notice any type of hormonal change from a vulvovaginal application of it. But obviously, your mileage may vary sooner than that.
I just want to go back to the other question about the bathroom issues.
Yeah.
In our Best of Holistic Healing Summit, we have a whole hour presentation all about bathroom issues, pelvic floor, and things that can help from a really great pelvic floor PT. So if you haven't donated yet, get that.
How or what procedures or treatments can be advised for loss of labia, fusion, or disappearance, waste to unfuse? So this is really where hormonal therapy using the emollients are really going to help, especially depending on kind of where you are in your menopausal transition. If you're there, making sure that there is adequate estrogenization to the labia, and then just kind of gently kind of making sure they're staying in their separate areas can be really helpful in keeping them from fusing together. Worst case scenario, like I said, we can go and unfuse them. That's going to be a surgical procedure in some cases, or you can do it in the office. But the treatment after that is going to be some kind of very aggressive hormone and emollient therapy to try and keep them in their normal place. So kind of same treatment there. You can PRP that too, honestly. But what was that, Kathy? Can you explain what's happening in the skin that causes fissure, tears, and the white spots? So what you're seeing is a change in the underlying kind of dermis or the skin layer underneath what we see on the top there. So as that's weakening and becoming like the actual architecture is changing, you're going to see it start to kind of space out, almost like develop like the best way to think about it is like a scar tissue, although that's not actually true. But that's a good way to think about it. And it's not strong at all. It's actually very, kind of easily torn. And that's why you'll see those kind of separations, usually along areas of stress in the skin. So around the perineum or on the labia, you may see these longitudinal cracks, or sometimes rarely lateral. Usually they're longitudinal. But it's basically where you've had an area that's separated. And fissures will form if that separation keeps happening over and over and over and over, and then it eventually just creates kind of this chasm. And that can get really bad to where you have this thing called a chronic granuloma fissuratum, which is its own thing. The white patches, though, where you're just seeing the underlying change as the loss of these things called reedy ridges and other histologic terms, without going too deep into it. As they are changing, they're just basically getting rid of a lot of the surface of the skin itself and changing the way it appears. So, like I said, the best way to think about it, I think, is kind of like scar tissue. It's not really scar tissue. It's much more weak and not as defined. If you have, it doesn't matter the location of the biopsy, or if you, so yes. So obviously, you want to, when you're doing a biopsy, you want to biopsy the area that has the worst or most like impressive skin changes if you're going for diagnosis. You can do it if you're not in a flare, totally, but if you have an area that is, you're like, yep, that's my main symptom area, that's typically where, you'd recommend it. So this may be on the perineum, this may be on the labia, on the clitoral hood. If it's on the clitoris itself, which can happen, I would caution you to make sure the person who's biopsying that has done clitoral biopsies before. We do our clitoral biopsies actually in the OR, because I do them under operating like magnifying glasses, and it's a whole different type of biopsy because it's so vascular, like the blood supply. So you can't do a typical punch biopsy and get samples out of it. You almost have to do like a shave. But it's like I said, you want to go to the area that has the most symptoms when you do the biopsy. So like I said, the big thing right now is that the clobetasol has all the data about the cancer reduction. That's really what it gets to, honestly, that, and it's covered. Betamethasone versus triamcinolone. So betamethasone is a stronger steroid. It's an ultra potent versus a triamcinolone. And so out of those two, triamcinolone works great for some things. It's going to help with itching. And if you have something like lichen simplex, which does not have that cancerous progression, possibility, triamcinolone's great. And triamcinolone may help with your symptoms without a doubt. But like I said, the big thing, it just doesn't have that cancer reduction. Because in treatment schedule, missing multiple. So it can, and this is one of the things we can see that may be the cause of a flare, actually. If you're on treatment and you stop it or you miss it a bunch, your body may freak out and say, oh my gosh, what happened? What happened to this, immune flare? And then you have your flare. So it is important to stay on. I know that daily application is rough for, it's either people tend to have a problem doing daily application, or they're like twice a week, they just forget about it. So, whatever you do, make a little note in your calendar on your phone or whatever, and kind of set a reminder, or do it around a normal time you would be getting dressed or undressed, before you go to bed, get dressed in the morning, something like that. That can sometimes help with reminding yourself to do it. So that's a great question. With HS, there's not necessarily a direct connection, except in that, it's once again kind of one of these autoimmune type skin things. Why do some people have hidradenitis? Well, we know there's issues with androgen receptors, and there's things kind of with the skin follicles themselves. So if something is affecting the skin, it may present as an HS type thing. It may be more of an LS. Autoimmune stuff travels in packs, unfortunately. And that's kind of where we see that connection. But otherwise, there's not a specific tie-in between the two. Emuade. Oh, so I've had some patients that have used Emuade before. Once again, I think if you are using it in addition to using the steroid, that's fine. That gets into the kind of therapy, treating the symptoms as opposed to treating the underlying condition. I would not do Emuade by itself, but I think in conjunction with clobetasol, if it helps, that's fine by me. The intergluteal cleft, sure. Once again, you can use it there. Now, like I said, it's with the skin thinning, it's all about the amount of steroid you're using. A little bit of steroid goes a long way. You don't have to have that area be wet with the ultra potents. So,
for those of us who aren't as smart as T, what is an intergluteal cleft?
So that's your butt crack.
Oh, okay.
Oh, sure. Yeah. No, it was funny. I was on vacation a few years ago. We went to Albuquerque and Santa Fe, and the house we stayed in Airbnb in Santa Fe, and they had a bidet, and I was like, I'm going to try this bidet. And I was like, I love this thing. I want to get a bidet. So no, there is absolutely nothing wrong with using a bidet for LS. You can bidet away. Small hard lumps on the labia normal with LS bites. No, not necessarily. I mean, if you're feeling, so the thing you want to figure out, is which labia, first of all, labia minora, labia majora. A lot of patients will get these little small, and they can be firm, bumps on more of the labia minora that are called Fordyce granules. They are just sebaceous glands and there can be tons of them. Those are completely benign. Now, other people, you can get cysts, you can get other things, but if you're feeling something that's very well demarcated, meaning you can feel all around and everything like that, and you feel a bunch of that, that would be something I would have looked at. Not typically something you're going to see with LS just by itself. So that is a who is better in your area question. You definitely can see. I mean, I'm a gynecologist by training. I have some colleagues. So the best thing, honestly, and I wish the ISSVD would do this. That's the Society for Vulvovaginal Disorders. Is put out a list or see who is a vulvovaginal person in your area. They may be a gynecologist, it may be a dermatologist. There can be multiple people that do that. You just want someone who is familiar with the condition. Honestly, it doesn't really matter their background, just as long as they know what it is and how to treat it. Oh, it's my pleasure to talk with you. So,
if you're enjoying this, please donate. I haven't seen a lot of dollars coming through, guys, and I appreciate everyone who's donated before. You guys, seriously, we cannot do this without you. And we need to have Dr. Babb back. We need to have some of our other experts back. Donations, please.
To put on. So I typically will do, if you're using a steroid ointment, that has enough of a moisture barrier in itself that you don't need to necessarily put something on that immediately afterwards. Like I typically tell patients to do twice a day application. So once of those is going to be of a steroid, the other part of the day is going to be of an emollient. You could even do it 3 times a day if you were doing kind of like your steroid in the morning, your emollient if you needed to, kind of after lunch, and then something again to kind of get you through the night. But I think typically twice a day is fine for that. Otherwise, as far as like how well it's going to help, I mean, you could put it on right afterwards. It's just going to be really goopy and messy. So I would probably wait, at least 30 minutes or so before putting it on if you're going to put it on directly afterwards.
All right. And this is our last question. It didn't all fit in one comment. So,
things like yeast infection could be the root cause of your health. Okay. Oh, okay. So let's go back to the first part of that. So this is the long one. So yeast infection or HIV could be the root cause for your LS flare. So obviously, once again, this goes back to kind of the immune uptake standpoint. A yeast infection can cause, if you think about kind of back to that slide that I did on pain receptors, if you have something where you're having this kind of chronic inflammatory, in this case, organism that's making everything angry, it's going to recruit those kind of nociceptors and it's going to make everything more itchy. And that could be the cause then of kind of that flaring symptom. If it's modulating your immune system, likewise, if you have a new onset yeast infection or it's the first time you're getting HPV or something like that, once again, that can cause that too, you get a heightened immune response and then you get a flare. JAK inhibitors, tacrolimus, contraindicated for patients that have HPV, or I think the other thing, was it a yeast infection? Can't remember the second thing. So a lot of times when you're using immunomodulators, so oral tacrolimus is a whole different story than topical tacrolimus. I would not do, if you are in the midst of a yeast infection and it's an honest to goodness yeast infection, the thing you have to be careful with is the steroid's going to make that get worse. So you got to get the yeast infection treated. Likewise, if you have chronic yeast infections, just in general, a lot of times rheumatologists, if you're doing immune modulators, even dermatologists, may not put you on JAK inhibitors because of that. So you want to get those things under control before starting, that type of therapy specifically. HPV is a little bit of a different story. Now, honestly, if you have genital warts, doing something that's going to affect, immune function may be a little bit trickier with your LS. And so this gets into the discussion of some of the other treatment options like imiquimod, which is an immune modulator for for HPV, for treatments for genital warts. Now you could try and do that. It may kind of change. I mean, it's gonna may make your LS get better with that, but remember, it's not a long-term treatment. Imiquimod can make vulvar HPV go away. It can get rid of those vulvar warts. Not so the same with imiquimod for LS, and that's not something that's really in a traditional treatment therapy kind of regimen. So that's something you'd really want to talk to a vulvar expert before kind of going on that treatment protocol.
Thank you. And I know we started a little late. Can you take one more question?
Sure. So these are those kind of what I was talking about, Fordyce granules or Fordyce spots. By them, there is not necessarily a connection between LS and those. We see them in patients who have LS. We see them in patients who don't. They are really just more of kind of how aggressive are your sebaceous glands, really, which cause sweat and kind of a buildup of this stuff called sebum, which keeps our skin lubricated. So.
And I'm calling out T. They're either a medical student or they are a doctor. But thank you, T, for all the amazing questions. Thank you, everybody, for all of your amazing questions. Please, it really, honestly, guys, if you could do $25, listen, there are 70 people on this call. If everybody could just do $25, we need to get to $25,000 by December 31st in order for us not to push back the provider education course that we want to create. So this is going to change the future of LS care. I mean, if you are asking all of these questions, it's because your doctor's not answering these, right? And so that's probably because they don't have the answers. So help us to get them the answers so they can answer them for you, or so that you don't even have to answer them because you're going to be in remission and you're amazing and not even thinking about LS. Okay? Or think about your daughter, your granddaughter, your sister. And there's a genetic component to this. Mm-hmm. It may not be until a generation or two. Do you want your future generation to go through what you went through? I know I don't. So please help us. Any amount really, really does help. And to the amazing supporters who have got us to 17,380, you guys are the best. Oh my God. Thank you so much. God, I got goosebumps. I just saw that number. And thank you, Dr. Babb, for your time. You are amazing. I love all of you. Thank you all for joining us tonight. And let's get it. Have an amazing holiday. This replay will be available on our YouTube page directly after in our live event. So if you missed the beginning, definitely go and rewatch it. You don't want to miss it. All right, guys, have an amazing, amazing night. And we will see you next time. Oh, Dr. Kraft, January 17th. We already got you for your next event. Donate today. Bye.